Good day, MT3. For this topic, we will be discussing your special test for hemostasis. For our learning objectives for this discussion is for you to be able to determine the functions and principles of the different special laboratory tests performed for hemostatic and coagulopathy disorders. So, in our discussion for this topic, we would be skipping some of the laboratory tests that were already discussed in the laboratory and were already encountered in your batch 1 cases. So, in this case, we would be focusing now on some of the laboratory tests that will help you in the upcoming cases, and also some of the laboratory tests that we have skipped and we have not encountered in our discussions. So let's start over now with your platelet aggregation and adhesiveness. So first off, we have your platelet aggregometry. So this one, we have already discussed ng pahapyaw sa ating mga batch 1 cases. Okay? Pero just to be clear with that one, we would be discussing this one. Okay, so in platelet aggregometry, guys, this is used in determining your platelet dysfunction because, again, one of our functions of your platelets is to have its aggregation with other platelets. Now, in this test, this is where your platelets are exposed to various aggregating reagents, which are known also as your agonists, and your platelet response is noted with it. Okay, now in our platelet aggregometry, it would have two phases. The first phase is the primary phase, wherein once your agonist is combined with the platelet, you would check now for its initial response. Now, the secondary phase or secondary aggregation, this is where there's additional aggregation that is caused by the release of your platelets ADP. Okay, yung natural ADP na niya. Diba, meron tayong ADP that is produced by your dense granules. Okay, so again, in platelet aggregometry, we have two phases. The first phase, which is your primary phase, wherein this is where you check for the initial response of your agonist plus the platelets response. And then after which, we go over now with your secondary phase or your secondary aggregation, wherein there would be additional aggregation that is caused by the natural release of your dense granules, ADP, which is also responsible in the aggregation of your platelets. Now, the principle of this test is that your aggregating reagent, your agonist, is added on a platelet-rich plasma, and at the same time, your optical density of the sample is monitored. Now, as the platelets in plasma clump or aggregate, your plasma becomes clearer. Thus, it would have a increased light transmittance. So, in platelet aggregometry, or also known as your light transmission aggregation assay, it has a similar principle with your spectrophotometry kasi both your spectrophotometry and your platelet aggregometry measures the optical density of your sample. Naalala sa spectro? Oo, diba? Nagsispectro pa kayo sa CC, right? Ayun. Now, naturally, in this case naman, in platelet aggregometry, naturally, your platelets should be able to respond to the agonist added because the function nga ng inyong platelets or one of the functions of your platelets is to be able to clump from one another. Again, our platelets function are your adhesion, activation or secretion, and also aggregation. So, naturally, again, kailangan magpa-function ng maayos yung aggregation function ni platelets. So, once you add your platelets or your platelet-rich plasma or yung sa patient's plasma nyo, and then you add also the agonist, it should naturally aggregate and form clumps from one another. Okay? And once it forms a clump from one another, magiging clear yung ating specimen, which would be measured in your aggregometry. Okay? Now, if you have a higher optical density, that means your platelet aggregation function is normal. Okay? Kasi nag-clear out siya. So, meaning nag-clump sila ng maayos, nagfa-function ng maayos ang ating aggregation. But, in cases of platelet aggregation dysfunction, the light transmittance would be reduced or decreased. There would be decreased optical density kasi nga your platelets did not clump from one another and therefore has a aggregation dysfunction. Hindi siya magki-clear out ng ganito, magiging hindi sila magka-clump from one another, ganito pa din siya. So, kapag mineasure nyo siya, you have decreased light transmittance or optical density. Okay? So, again, in platelet aggregometry, your platelets aggregate, which allows increased light transmission, and if not, then therefore it means to say the patient has a platelet aggregation dysfunction. So, in this example, you can see different agonist results. No? Meron tayong ADP, adrenaline, collagen, at saka ristocetin. Now, aside from these agonists mentioned, we also have other agonists such as your arachidonic acid at saka si epinephrine. Okay, I think na-encounter naman natin sila sa laboratory cases. Okay, so back to the example here in our screen, you could be able to see that results show a normal aggregation to ADP, adrenaline, and collagen. Kasi naging normal yung kanilang light transmittance. So, meaning to say, naging okay yung aggregation results nila in response to these different agonists. Okay? Now, lahat meron siyang normal response except with ristocetin, as you can see here. Okay? Now, the initial response, which is in color blue, has a normal response. However, on its second aggregation or second phase, hindi na siya normal. Hindi na nag-aggregate or nag-clump ng maayos yung ating platelets. So, therefore, this patient result may have a platelet aggregation dysfunction. So, anong probable na sakit na pwede meron si patient niyan? Remember, di ba, there is a disorder that is associated with platelet aggregation dysfunction, and it has normal results to all agonists except for ristocetin. Sino kasi yun? C, B, S, S. Tama? Tama. Okay? Next test we have is your Salzman method, which measures the platelet function of adhesion. Okay? Now, this test is useful for the following results. If you have decreased adhesion, these are associated with disorders that have adhesion dysfunction. Okay? And ano kasi yung mga yon? These are your von Willebrand disease, Shedrak-Higasha syndrome, your Glanzmann thrombasthenia, and ingestion of your anti-platelet drugs such as your aspirin. Okay? Now, if you have also increased adhesion naman, these are disorders associated with thrombotic disorders or the production of your thrombosis. Okay? Now, these are your venous thrombosis, pulmonary embolism, splenectomy, and intake of oral contraceptives. Now, the specimen of choice in this test is your EDTA whole blood that is collected in two ways. So, meron kayong dalawang EDTA whole blood. The first EDTA whole blood is collected through the routine venipuncture, and the other EDTA whole blood is collected through the use of a glass column or glass bead collecting system. Now, from your two EDTA whole blood specimen, they would undergo or you would perform platelet count, and then the number of the platelet count should be noted. Now, the result should show that there should be a lower platelet count that would be observed in the specimen collected in the glass bead compared to the specimen collected in the routine venipuncture. That is because your platelets, one of its functions nga naman is to be able to adhere itself to a surface area once there would be the presence of tissue injury. Now, in vitro, we use the glass to indicate or would represent the area or the contact area for your adhesion. Now, your platelets would naturally adhere to the glass column or glass bead, which would indicate that the adhesion function of your platelet is normal. Okay? But after the computation using this formula, percent platelet adhesion, wherein it is equal to the platelet count without, ito yung routine venipuncture, minus the platelet count with the beads, so ito yung may glass, divided by the platelet count without the beads, ito yung veni, times 100. Now, if you get a lower percent platelet adhesion, that means to say that the patient may suffer from platelet adhesion dysfunction. Kasi, hindi nagkikling ng maayos yung mga platelets doon sa ating glass bead, and therefore, you would expect a lower result in this computation. Okay? Now, if naman, the other result naman, if you produce a increased percent adhesion, that means to say, masyado silang nagkikling from one another doon sa glass bead natin, then that indicates for thrombotic disorders or the formation of your coagulopathies or increased coagulation. Okay? Ayun. Now, these tests, si Salzman method, guys, this is usually not done anymore and is an obsolete test because this is a non-specific test. It's not only solely for adhesion kasi the aggregation also occurs at the same time in the glass bead. Okay? And diba after adhesion there is the process of aggregation in the hemostasis. So hindi naging specific for adhesion lang yung ating Salzman method, and therefore is already considered obsolete, and it's not reliable and accurate for you to be able to determine the adhesion function of your platelets. Let's proceed now with your different coagulation tests. And again, we would only be discussing the tests that were not thoroughly discussed in the laboratory and may also be helpful to you in your upcoming cases. And one of which is your thrombin time. Your thrombin time is also known as your thrombin clotting time. This is used to measure the available functional fibrinogen and is also useful in determining different fibrinogen deficiencies such as your fibrinogenemia, your dysfibrinogenemia, and your isa pa si hypofibrinogenemia. Okay? Aside from that one, this is also useful in determining the presence of heparin and other thrombolytic agents. Okay? Now, anong ginagawa natin sa thrombin time? Similar lang siya with, with PT at saka kay PTT. You have your patient's plasma, and then your reagent in this case naman ay si thrombin. Okay? So, you combine them together, and then once you combine them together, you record the clotting time. So, you check for the gel-like clot formation in your specimen. Okay? Now, the normal values for this test is 10 to 14 seconds. Now, we use thrombin as the reagent kasi nga, your thrombin or si factor 2A, okay, ano kasing function niya? Ang function niya is to be able to convert your fibrinogen to fibrin. Okay? So, if you add this thrombin, you would be able to know if ilan pa yung functional fibrinogen na meron si patient. And therefore, you could be able to assess whether the patient have a factor 1 deficiency or not. Okay? Now, in patients with prolonged thrombin time, that means to say their fibrinogen levels are mababa. Okay? Kasi konti lang yung nagpa-function na fibrinogen, and therefore, mabagal yung kanilang clotting. And usually, their fibrinogen levels are only between 75 milligrams to 100 milligrams per deciliter. Okay? Eh, di ba ang normal range natin for the levels of your fibrinogen is 200 to 400 milligrams per deciliter. So, meaning ito, sobrang baba na ng kanilang fibrinogen levels, and therefore, if mababa ang fibrinogen levels nila, mababagal din ang kanilang coagulation or clotting. Next test is your Dockert's test, which is a solubility test for factor 13. Your factor 13 is your fibrin stabilizing factor, which is important for you to be able to stabilize your clot in the coagulation mechanism. Okay, now the main reagent that we use for Dockert's test is your 5 molar urea. Other substitutes that can be used as a reagent for Dockert's test is your 1% monochloroacetic acid and your 2% acetic acid. Now, in Dockert's test, you have your patient's plasma combined with your calcium chloride. Your calcium is important in the coagulation mechanism as it functions as a cofactor in the different serine proteases of your cascade. Now, once you add your calcium chloride to your patient's plasma, you are now able to form your clot. After the formation of the clot, you now add your reagent, guys, which is your 4 molar urea. And usually, guys, these reagents that are used in Dockert's test could easily dissolve your fibrin strands or your fibrin monomers. Okay? Pero dahil meron tayong factor 13, kailangan hindi madaling mag-dissolve yung ating clot. So, after the addition of the 5 molar urea or your other reagents, your clot should not be able to dissolve within 24 hours. If your clot was not able to dissolve within 24 hours, that means to say your coagulation factor 13 is functionable. But after 24 hours, your clot has dissolved completely, so na-dissolve. That means to say that your factor 13 is not present or absent or pwedeng deficient siya. Okay? Kasi hindi niya na-stable ang ating clot and therefore was easily dissolved by your addition of the reagent. Okay, nakuha ba guys? Again, in Dockert's test, you have your patient's plasma and your calcium chloride forming now your clot. Now, in the presence of your coagulation factor 13, your clot should not be able to dissolve within 24 hours once you add your reagent 5 molar urea. But if your coagulation factor 13 is absent or deficient, your clot would dissolve easily once there is the addition of your reagent 5 molar urea. And that is why your Dockert's test is also used as a screening test for factor 13 deficiency. Next test are your venom-activated assays. So one of which is your steep vent time. Your steep vent time is also known as your Russell-Viper venom time. Now, this venom-activated assay is historically used to determine factor 10 deficiency. Pero eventually, this test is commonly used to detect any deficiency in the common pathway. Kasi nga, si factor 10 yung start ng common pathway. Dati akala kasi nila, kapag prolong na sa RVVT, automatically deficient na siya ng factor 10. Pero, if you're going to come to think of it, pwede namang na-activate si factor 10, pero baka meron palang deficiency in the succeeding factors such as your factor 5, 2, or 1. Okay? Now, the venom that is used as a reagent in steep vent time is your Daboia ricelli, or from your specific species of snake, which is Vipera roselli. I think, para siyang pit viper na snake. Hindi ko lang sure anong tawag sa snake na yun. Basta yun. Okay? Now, it has a similar principle with your thrombin time. Meron kayong patient's plasma, tapos i-add mo yung reagent mo. In this case, yung reagent mo ay yung venom. Tapos, after mo mag-add, i-check mo yung clotting ng specimen mo. Okay? Now, if you have prolonged Steven time, that indicates for deficiency in factor 10 or other factors present in the common pathway. Next venom-activated assay is your reptilase time naman. Okay? Now, the snake venom naman na ginagamit natin sa reptilase time ay si batroxobin. Okay? Now, this batroxobin is a thrombin-like enzyme. So, para siyang thrombin. Pero, galing nga lang siya sa venom ng snake. Okay? Kaya, ang tawag sa batroxobin ay reptilase. Okay? So, the reagent that we use in reptilase time is your reptilase. Okay? This venom comes from your specific species of snake, which are your Botrops atrox and your Botrops mugeni. Okay? Now, similar lang din with thrombin time and steep vent time, si reptilase time. You have the patient's plasma and then you add it with your reagent. In this case, ang reagent natin ay si reptilase. And then, after nun, i-check mo yung presence ng clot. Okay? Now, your reptilase time is much preferred as compared with thrombin time kasi your reptilase time is insensitive to heparin. So, even if the patient is undergoing heparin therapy, hindi siya maghihinder para ma-determine nyo if the patient suffers from fibrinogen deficiency such as your dysfibrinogenemia. Okay, unlike citrombentine. Citrombentine is sensitive to heparin, if you can recall a while ago. Okay, now the normal values for reptilase time is 10 to 15 seconds. Another venom-activated assay is your dilute Russell-Viper venom test. It has a similar reagent with vent time, which is C. daboia reselli. No? However, in this case, your reagent is diluted because it is used as a inhibition test in the detection of the presence of your lupus anticoagulants. The normal value for this test is 30 to 35 seconds. Now, in the presence of lupus anticoagulants kasi guys, once your reagent, which is the daboia reselli, together with your phospholipid, calcium, and your factor V, is added into the patient's plasma, some of the phospholipids would be attracted to your lupus anticoagulants and thus would be neutralized and thus would prolong the clotting or the formation of your clot in the coagulation mechanism. So, if you have prolonged results in the DRVVT, that indicates that there is the presence of lupus anticoagulants. Next are your factor substitution assays, more commonly known as your mixing studies. Now, your mixing studies is used as a screening test in determining whether the patient has the presence of circulating anticoagulants or factor deficiencies. Now, you only perform mixing studies when you are able to obtain abnormal pro-time or partial thromboplastin time results in the patient's plasma. Now, in mixing studies, you have your patient's plasma combined with a normal pooled plasma and combine them together and check for correction or failed for correction. Now, after mixing your sample with a normal pooled plasma and we're able to correct the sample, that means to say that the patient has a factor deficiency. Okay? But after combining it with a normal pooled plasma but fails to correct, that means to say there would be the presence of your circulating anticoagulants. Here's an example of your mixing studies. Okay? Ang una natin tinitignan sa mixing studies ay yung result natin for pro-time at saka si PTT. Again, your pro-time detects for coagulation deficiencies present in the extrinsic and common pathway, while your PTT checks for coagulation deficiencies present in the intrinsic and common pathway. You would only consider the common pathway if both your pro-time and your PTT are abnormal. But in our case, in our example, PT is normal and the PTT is abnormal. So therefore, the pathway that have the coagulation factor deficiency is present in the intrinsic pathway. And your factors present in the intrinsic pathway are your factors 12, 11, 9, tsaka si 8. Tama? Okay. Next, let's proceed with your first reagent, which is your normal pool plasma. Your normal pool plasma contains all your coagulation factors. And in our given, it was corrected. So, meaning to say, the problem with this case is a factor deficiency and not the presence of circulating anticoagulants. Okay, so meaning, itutuloy natin siya kasi ang problem ay factor deficiency. Okay, next, on the next set of reagents, you're going to look now on the not corrected. Okay, ang not corrected natin ay si adsorb plasma. Okay, now ano kasi ang mga factors na hindi present or absent kay adsorb plasma? These are your factors 2, 7, 9, and 10. Okay, and then you now check for the factor that is present in the intrinsic pathway and also not present in your adsorb plasma. And that is your factor 9. Okay? So, meaning to say, in this case, the deficiency is factor 9 deficiency or your Christmas factor deficiency. Okay? Now, how would you able to know na tama ang inyong sinagot? Titignan nyo naman yan si corrected. Okay? Titignan natin ang mga corrected results. Si age serum. Kung may factor 9 deficiency ka ba, makokorrect ba siya sa age serum? The answer is yes, kaya corrected siya. Kasi, meron naman siyang factor 9. Tama? Ito lang yung mga absent sa kanya. Okay? Another one, you have your age plasma. If you have factor 9 deficiency, would it be corrected in the age plasma? The answer is yes, it would also be corrected because your age plasma also contains factor 9. Dahil ang wala lang sa kanya ay si factor 5 and factor 8. So therefore, tama yung sagot mo na the deficient in this case is factor 9. Okay, another example. We have your abnormal ProTime and abnormal PTT. So, therefore, the problem is with the common pathway. Okay, so meaning yung coagulation factor deficient ay nasa common pathway. Your factors present in the common pathway are factors 10, 5, 2, and 1. Okay, next. Normal pool plasma is corrected. So, meaning to say it is a factor deficiency nga. Okay, next, you're going to look now at the reagents that have not corrected. And these are your age serum and your age plasma. The factors not present in age serum are your factors 1, 2, 5, 8, and 13. And then on age plasma, the factors not present are your factors 5 and factor 8. Okay? Next, hanapin natin sino yung may pare-parehong factor sa common age serum at age plasma, and that is your factor 5, 5, 5, 5. So therefore, the factor deficiency in this case is factor 5 deficiency. Okay? Double check natin kung tama yung sagot natin. Titignan natin si adsorbed plasma na corrected. Okay? If you have factor 5 deficiency, would it be corrected in the adsorbed plasma? The answer is yes, it would be corrected because your adsorbed plasma contains factor 5. Kasi ang wala lang naman sa kanya ay si factors 2, 7, 9, and 10. So, tama na yung sagot natin. Factor 5. Kuha ba guys si mixing studies? Okay, ayun. Last topic for our special test for hemostasis are the tests for DIC or fibrinolysis. First off is your D-dimer test for the presence of fibrin degradation products or FDPs. Again, your D-dimer is a degradation product of your stable fibrin. Now, this D-dimers indicates for proper fibrinolysis function. So, meaning to say, nag-function na maayos ang ating fibrinolysis kasi nade-degrade ang ating fibrin into FDPs and also D-dimers. Now, in increased presence of FDPs and D-dimers in the circulation may indicate for the following disorders: either DIC or disseminated intravascular coagulation, systemic fibrinolysis, deep vein thrombosis, and pulmonary embolism. Okay? Now, the most common D-dimer test that is also commonly used at present is your quantitative D-dimer assay. Its principle is your patient's plasma is diluted and mixed with latex particles coated with your monoclonal antibodies to the D-dimer. Now, you check for the presence of your D-dimers and your fibrin products, and therefore, agglutination of these latex products will occur. Now, a normal value should be less than 0.5 micrograms per ml. If there would be a greater than 0.5, then that means to say you have increased D-dimer, so meaning very active ang ating fibrinolysis, which is also an indication for either thrombotic or bleeding disorders. Next is your ethanol gelation test. This is used to detect the presence of fibrin monomers in the plasma, and this is also used as a screening procedure to help in the diagnosis of your DIC. Now, in the presence of DIC, your fibrin levels in the blood also increases because of increased activation of your coagulation and also increased fibrinolytic system. Now, your sodium hydroxide, which is the reagent in this test, is added to the plasma to be able to increase the pH to above 7.70. Now, once your pH is increased, your ethyl alcohol is added into the plasma and will cause precipitation of your fibrin monomers, which are then measured. Increased levels of fibrin monomers indicates for the presence of DIC. Last test for DIC or fibrinolysis is the euglobulin clot lysis test. This is a screening procedure for the measurement of any fibrinolytic activity. Now, among the clot lysis tests, this is the most sensitive compared with the other methods. This is used to measure the presence of euglobulin, which is a fraction of plasma that contains your plasminogen, plasminogen activators, and fibrinogen. Now, in the principle for euglobulin clot lysis test, a venous blood is collected into the chilled tubes containing trisodium citrate as an anticoagulant and placed on ice. Now, this sample is then centrifuged at 4 degrees Celsius and plasma sample is collected and diluted with your acetic acid as your reagent. Afterwards, it is incubated on ice for 15 minutes. Once clot is formed, clot lysis occurs quickly than in the whole blood. Now, in euglobulin clot lysis test, a normal clot lysis should not occur in less than 1 hour using the procedure. Now, if there would be increased clot lysis, this indicates for abnormal fibrinolytic activity which may be associated to bleeding or thrombotic disorders. So these are the references for this topic, and thank you for listening.